Good morning. Welcome. Really excited about today's program with AVIK ROY and GUIAN McKEE on the conservative case for healthcare. Healthcare is, on the one hand, a bipartisan issue. 6 in 10 Americans say it's the federal government's responsibility to make sure all Americans have healthcare coverage. 31% support a single-payer approach to health insurance. But even 55% of Republicans say the government should continue programs like Medicare and Medicaid for seniors and the very poor. And only 10% of Republicans say the government should not be involved in providing health insurance at all. Then again, as we saw in the President's State of the Union, there is a rising chorus about the Democrats bringing socialism, particularly through the new rallying cry of Medicare for all. It is an interesting moment to explore this issue, and we're really delighted to have AVIK ROY as our guest. He is going to be interviewed by GUIAN McKEE. GUIAN is the associate professor in presidential, it is an associate professor in presidential studies here. He works extensively with our presidential recordings program, including, in particular, understanding the origins of the Medicare and Medicaid program in the mid-1960s through the Lyndon Johnson tapes. He has his PhD in American history from the University of California, Berkeley, and he's currently working on a book that examines the rise of the healthcare economy in American cities after World War II. He focuses on the development of hospitals as critical but problematic and challenging urban economic anchors. They drive both the costs of the larger healthcare system, but are the major providers of healthcare in many of our cities. And he offers an alternative narrative of healthcare policy history and of healthcare reform by focusing on the consequences of healthcare spending. Just to give you a sense of that and how GUIAN has helped me understand how healthcare centers in places like Baltimore around Johns Hopkins, or even here at UVA in Charlottesville, the research and teaching part of UVA is a $1 billion economy. And it's matched by our health system, which is a $1 billion economy. So we live in a healthcare town, even if we don't think about it that way. And it impacts how our city is planned and built and operates in really important ways. So I'm delighted to have GUIAN introduce AVIK and lead us in conversation after AVIK's presentation.
Good morning, everyone. Welcome to the Miller Center. This is actually the first of what we anticipate will be at least 2 events coming up on the future of healthcare policy as we look toward the 2020 election and beyond. Broadly, one from the right and one from the left, but really in many respects, and as we're going to hear today, more about opportunities for crossing those old and increasingly tired boundaries in this policy area. And it's one of the key things that AVIK brings to this conversation. I'll also note that we will hear more about the topic at the Miller Center's Presidential Ideas Festival coming up in May. Our guest today is AVIK ROY. AVIK is the co-founder and president of the Foundation for Research on Equal Opportunity, or FREOP, based in Austin, Texas. He is a graduate of MIT and the Yale School of Medicine, and he has also worked in biotech finance, among other places, at Bain Capital. In 2009, during the debate over the Affordable Care Act, AVIK began writing about healthcare policy, first on his own blog, known as The Apothecary, and then for National Review, and later for Forbes magazine, where AVIK now serves as opinion editor. In the political world, he served as a healthcare policy advisor to Mitt Romney's 2012 presidential campaign. During the 2016 campaign, AVIK worked on Rick Perry's presidential campaign as both foreign and domestic policy advisor, and also as a primary speechwriter. After Perry left the race, he served as an advisor to Marco Rubio's campaign. He then co-founded FREOP, a think tank dedicated to the promotion of market-based policies aimed at helping Americans with below-median incomes or net worth. In recent years, he's also emerged as a leading conservative voice, challenging the direction in many respects of the Republican Party on both racial and economic policy issues. He's also served on the board of advisors for the National Institute for Healthcare Management Foundation and the Concerned Veterans for America's Task Force on Fixing Veterans Health Care, which he co-chaired. AVIK is widely regarded as one of the most innovative and interesting conservative thinkers on healthcare policy today. It's my pleasure to welcome him back to the Miller Center. AVIK.
Thanks, GUIAN, and thanks also to everyone for being here today, and to the University of Virginia, which is always a pleasure to come back to, one of my favorite college towns and college campuses. I'm gonna bombard you with a lot of charts today, so I hope you have your coffee. What I'm going to try to do is explain how I got involved in this and how actually, we all know healthcare is important, but a lot of the principles I'm going to describe when it comes to healthcare reform are more broadly applicable to our political system and our public policy debates. That's why we founded the Foundation for Research on Equal Opportunity. If you think about a lot of the what you see on cable news, right? If you watch cable news all day, your impression of American politics is there are these two parties, they hate each other, there's no opportunities for agreement on anything. I think most of us in our daily lives don't have that experience. We actually see a lot of agreement among the people we talk to about the aspirations we have for our country. We generally want everyone to have a fair shot to get ahead. We may not all agree on exactly how to do it, but that general idea that every American should have the opportunity to succeed wherever they came from, whatever their economic status is something almost every American believes, and public survey data shows this over and over again. And so while our mission is to conduct public policy research that expands economic opportunity to those who least have it, and that may seem like a common aspiration of a lot of institutions, what's really different about FREOP, which we founded in 2016, is that we're genuinely trying to advance both conservative and progressive values at the same time. Now you may think, how is that possible? How can conservatives and progressives agree on anything? Well, think about a recent bill that passed Congress and was signed into law by the President called the First Step Act, which is a modest step at criminal justice reform. That was an example of people on the left and people on the libertarian right getting together with people in the Trump administration, Jared Kushner among others, to actually find ways to say, okay, we are incarcerating too many people in America. And while this bill doesn't solve every problem, it was a way for people on the progressive side who were concerned about that problem because of inequality issues, and people on the right who were concerned about that problem from a liberty standpoint, coming together, not compromising, but actually both sides being able to say, we advance our values. That's true in healthcare too. And so that's why our focus is on market-based ideas that meaningfully improve the lives of Americans whose incomes or wealth are below the US median. So why do we have that formulation? It's because the market-based side of it is what appeals to Republicans maybe traditionally, but the inequality piece, or the focus on people on the bottom half of the economic ladder, that's a progressive piece, right? So that's the part that's about reducing economic inequality in America. And there are ways to harness the innovation of the private sector to help achieve those goals. And if you can do that, if you can find ways to do that in healthcare and in other areas, then you really do have a bipartisan consensus. And bipartisan consensus isn't just some, Pollyanna-ish thing. If you want to get real reform through the Senate, you have to get 60 votes. And by and large, if you want to get 60 votes in the Senate, you have to have Republicans and Democrats, at least some of them, to agree. So this is not just again, a wishful thinking approach to policy. This is actually the most pragmatic approach to policy you can have, which is no real reform can actually advance unless you can get Democrats and Republicans to agree. You can't get Democrats and Republicans to agree unless you're advancing conservative and progressive values at the same time. And that's why we're structured and designed and oriented the way we are. So how does that relate to healthcare? This picture is from a debate I was having at Stanford at the Hoover Institution, and the guy next to me with the beard, his name is John Podhoretz. He's a well-known conservative commentator. His father is considered one of the founders of the neoconservative movement. And this is what John had to say as we were chatting about the repeal and replace aspirations of Republicans in 2017. He said he thought he was complaining about the Republican bill because it went too far to cover the uninsured. He said that the idea that Republicans were conceding, that it was basically Republicans had surrendered their values because the idea that there should be universal coverage in the United States is a left-wing idea. It's not something conservatives should support. That was never a conservative or Republican goal. We've accepted an essential social democratic principle, and that's a huge concession. Well, here's something that's really interesting about that. So the Heritage Foundation, as many of you know, is one of the most, if not the most famous conservative think tank in Washington, and every year they put out a list of all the countries in the world ranked by economic freedom. The U.S., in the most recent version, which just came out a couple weeks ago, ranks 12th. And here's what's interesting about that, is that all of those countries, except for the United Arab Emirates, has universal coverage. So if America is somehow surrendering its freedom to achieve universal coverage, why is it that the Heritage Foundation, no left-wing conspiracy, believes that there are 10 countries that are more economically free than the United States that have managed to provide health insurance to every single one of their citizens? One thing that's really important to understand about this is not every country that has universal coverage does it in a single-payer way in which the government is the only insurer. That's a widely held misconception in this country, both on the left and the right. People on the right oppose universal coverage because they think the only way to do it is through a government-run system. And a lot of people on the left don't always appreciate that there are market-based ways to achieve universal coverage. And the two countries I've highlighted at the top of that list, Singapore and Switzerland, are two examples of countries that actually have healthcare systems that are more market-oriented than the United States' healthcare system, but cover everyone and have much better outcomes than we do. And that, to me, is something that really can help liberate the thinking of a lot of conservatives. And again, it's a way to advance conservative values and progressive values at the same time. Universal coverage, a progressive value, but a more market-based system in which that's more fiscally sustainable, that's a conservative value. So we don't have to be fighting with each other all the time on health care if we identify reforms that can do both of those things at the same time. This is the chart that I know is going to be hard to see because the numbers are really small, but this is the most important chart I'm going to show you today. And what this chart is showing you, so you've all seen, if you care about healthcare policy, you've all seen the chart that says America spends 18% of its GDP on healthcare, and the European countries spend between 9 and 11% typically, and our outcomes and our results and our uninsurance rates aren't really good enough to justify that, right? That's the chart you normally see. That's what I call the blah, blah, blah chart about healthcare economics. What this chart is showing you is something different, which is government spending per capita on healthcare in the industrialized economies. And in 2013, the last year before the Affordable Care Act went into effect, so this excludes the effect of spending from the ACA, government spending per capita on healthcare in the United States was the 5th highest in the world. That's including the fact that we had 50 million people who are uninsured. So think of how profoundly inefficient your system has to be when you have 50 million people who are uninsured and you're still spending more per capita on healthcare from a government standpoint, not private spending, than almost every other country in the world. And so when advocates of single payer point to the UK and Canada, those are the two blue lines there, and say, hey, single payer doesn't have to be expensive. If you look at the UK and Canada, they actually spend less per capita than we do and cover everyone. There's an argument for that, right? So conservatives who simply say, no, I'm against single payer because we can't afford it, don't actually appreciate that single payer countries have managed to cover everyone in their countries and spend less than we're spending. Now, they do it in ways that conservatives might not like. They have price controls. They restrict access to expensive kinds of healthcare services in ways that a lot of Americans wouldn't like. But the point is, in terms of the pure fiscal ability of a country to have universal coverage and spend less money, the UK and Canada are countries that have done it. But you'll notice there are a lot of countries to the left of the UK and Canada on that chart, and we're going to touch on that later. The debate we've been having for the last 10 years, of course, has been about Obamacare, what Paul Ryan called the government takeover of the healthcare system. And it's true that the Affordable Care Act did expand the role of the government in the healthcare system. I don't think that's controversial. One way to measure that is by looking at the amount of federal spending, new federal spending that the Affordable Care Act enacts in order to cover the uninsured. And these are the official Congressional Budget Office estimates. Once the ACA gets fully up and running, it's spending about $200 billion a year covering the uninsured. That's real money, even in Washington. If you compare that to our defense budget is about $800 billion a year. So we're spending a quarter of the defense budget to cover the uninsured. That's a real commitment to covering the uninsured. Now, in fairness to the ACA, this spending increase is partly offset by reductions in spending in Medicare. So the ACA cuts Medicare spending by $800 billion over 10 years to partially offset the $2 trillion increase over 10 years in coverage for the uninsured. So if you net that out, it's more like $75 billion a year, but still, it's an increase in federal spending from what it was before. So if you're the kind of person who doesn't like to see federal spending go up, you have reasons to object to Obamacare. But then we have to ask the question of what was the federal government already spending on health care before the ACA? And that's what these red bars are going to show you. So we don't have enough stories in the Miller Center, even though it's a beautiful building, to display this chart, so I'm going to compress it for you. So the blue part of that chart is the government takeover of health care, according to Paul Ryan, and the red bars are the real government takeover of health care, which happened in 1965 when we passed Medicare and Medicaid. The point is that for the last 10 years, we've been fighting over that blue piece. So all the conservatives, all the Republicans who are saying, we've got to repeal Obamacare, that's the most important health care issue we have in this country. The fact is, if you're concerned about the deficit and the debt, Obamacare is a drop in the bucket. The real problem is the overall growth in health care spending, again, not just by the government, but by the private sector as well, by average people and their insurance premium. That's the problem we have to solve. Here's another way to bring this into a larger context. The Congressional Budget Office every year, which is a nonpartisan scorekeeper in Washington, as many of you know, that forecasts our fiscal situation, they put out a 75-year projection. Now, it's hard to project 75 years in the future, as we all know, but the idea here is if the laws on the books today stay the laws on the books, what is the federal government committed to spending? And what I've done is I've broken the categories of spending into two categories. The red is healthcare and the blue is everything else. So you can see as a share of our economic output, the only thing that's actually growing is healthcare. The blue includes the defense budget, Social Security, everything you think the federal government should or shouldn't be doing, education funding, highways, that's all in the blue. So that's actually pretty stable as a share of our economic output. That's not the part that's bankrupting the country, it's the red part. Well, actually I lied. There's one other category of growth in federal spending, interest on the federal debt. So we're never going to get to 2050 on this chart, because just like you, if you borrow money on your credit card for years over years, eventually the bank pulls the credit card. In our case, the bank is China, which buys treasury bonds to finance our debt. And if people stop buying treasury bonds, then our interest rates are going to skyrocket. So that green part of the chart is going to go even steeper up in the air, and we'll be in real trouble. And so if we don't solve this problem, if we don't solve the problem of the growth of federal health care spending, who's going to suffer? It's not going to be those of us who are upper income who can afford private coverage and don't rely on federal subsidies. It's going to be the poor, the vulnerable, the elderly, the people who otherwise can't afford health insurance without government assistance. Those are the people who are going to face Greece-style draconian cuts in health care spending over the long term if we don't solve this problem in the near term. Here I'll give you a kind of a trivia point that captures this. Within 10 years, we're going to be spending more on interest than we spend on our entire defense budget. So this is not a problem of the far-off future. This is a problem that we'll be facing in the very near term. And what happens when we get to that point? When interest on the federal debt is a bigger share of our budget than the defense budget. So, okay, we break it down. What are the big drivers of healthcare spending? Usually when people talk about healthcare spending and it's high cost, the hospital people will say, yes, it's true that healthcare is too expensive. That's why we have to really hammer the insurance companies. The insurance companies say, hey, it's true that healthcare is really expensive. That's why we have to have the hammer of the drug companies. And then the drug companies say, it's not our fault. The doctors write the prescriptions, blame them. And the doctors, of course, blame the lawyers. So everyone has somebody else they blame, and what I'm here to tell you is everybody is to blame. Every part of our healthcare system is way more expensive than it is everywhere else. Here's, again, I know I have a lot of charts here, but there's a reason for that. Because people talk about healthcare, there's all sorts of cliches, but the numbers tell a different story than the cliches. Here's a good example. There's a cliche you'll hear in healthcare reform all the time. People will talk about the movement from volume to value. They'll say, we've got to change the delivery of healthcare so we're not doing wasteful procedures, right? Well, here's something really interesting. If you actually look at wasteful procedures in the healthcare system and compare the United States to other countries, and you look at various ways of measuring that, America actually is not too bad. One standard example that you can look at is the average length of stay in a hospital. So for every time you go to the hospital, how long are you in the hospital? Because the longer you're in the hospital, the more expensive that episode of care is. Well, it turns out the U.S. is 2 days more efficient than the industrialized world. So we get in and out of the hospital faster. Why? Because we have better technology and we're actually more efficient at making sure we get people out of the hospital more quickly. I'd say don't get hospitalized in Japan, but maybe the Japanese hospitals over there are really nice, so maybe people want to stay in a hospital for 28.5 days on average, but I'd rather be the U.S. and get in and out quicker. Now, the point of this is you'll hear people say, let's be more efficient. We already are more efficient. The problem is not that there's a lot of wasteful spending in the hospital, it's that every day in the hospital is 5 times more expensive in the United States. And that's not because we're doing 5 times as much stuff to the patient. It's because the MRI is priced 5 times higher. The respirator is the charge for the respirator is 5 times higher. Everything that we pay for in an American hospital, the price is 5 times higher than it is in another country. So it's not that we're overutilizing healthcare. It's not because we're all fat and sitting around eating Doritos watching college basketball. It's because we're actually just the price for every service and good in the U.S. is higher. And it's not just hospital care. I'm not here to only beat up on the hospitals, though I have one more hospital chart here. This is the craziest chart. This is the craziest chart I'm going to show you, and it's not the most important, but it's the craziest chart. So this is the chart that shows you the tax rate, the federal tax rate, income, payroll tax, all the taxes that an average middle-class family pays for a household of median income. So it rose up for a little bit, and then after the recent tax cuts, the middle-class tax rate effectively went from 14.8% to 13.8%. So it's going to be in the high 13s unless Congress changes it again. So the average household is spending about 13.8% of its income in federal taxes. But the average family's share of national hospital spending is now 15% of household income. And it's going to rise to 18 and 19% within a decade. We're getting to a point now where what the average family spends on hospital care, whether it's directly or through insurance or through taxes, is more than what we spend on actual taxes to the government. That's crazy, right? And the reason I bring up this chart is for Republicans out there who think that tax cuts are the solution to every economic problem that middle-class families face. That's no longer true. The cost of health care is a much bigger problem for the average family's disposable income than their taxes. Okay, so I mentioned the high price of hospital care. It's also true of doctors, right? The average office visit in the United States to a physician is 3 times or 4 times or 5 times higher than it is in other countries. I don't have to tell you about the fact that we spend more than any other country on prescription drugs. You already know that. But here's something you might not know, which is that, again, if you think about generic drugs, which are the cheapest drugs in the system, the primary way you can actually lower the cost is to actually use generic drugs where it's more appropriate to do so. Guess what? The country that has the highest share of utilization of generic drugs is the United States at 86%. Actually, it's actually 90%. This is 2015 data. Today, it's 90%. 90% of all the prescriptions written by doctors in the United States are for unbranded generic drugs that cost less to manufacture than a bottle of Poland Spring water. So we're better than all these other countries at substituting generic drugs for costly branded drugs. And yet, that 10, 14% of the market that is branded drugs, that's where the prices are out of control, way higher than every other country in the world. So again, the problem here is not efficiency. It's not actually waste in the sense of wasteful utilization of costly services. We're actually pretty good compared to other countries in the world on that score. The problem is that the prices that we pay for every good or service in healthcare in the United States is higher than anywhere else. And here's another way to look at this the drug data. Generic drugs, I mentioned to you that 90% of the prescriptions now are for generic drugs. Overall national spending on generic drugs is flat. And this doesn't even take inflation into account. If you take inflation into account, it's actually declined. The dollar amount that we're spending on generic drugs has declined, which is remarkable because there are more and more prescriptions for generic drugs as more and more drugs go off patent. But here's what the patented drugs spending growth is. That's where all the growth is, right? So if you actually look at the overall growth in drug spending, it actually understates the problem. Because if you take out the generics piece and only look at the branded piece, basically drug spending has gone up by 50% in the last 4 years. 4 years. Okay, so that's the data. So now we have to ask ourselves, how did we get here? Right? Because any doctor knows you can't actually treat the patient unless you know what caused the patient's disease. The same is true with our healthcare system. How do we go from this lovely system where people in white coats would come visit you in your house and all that to the planet-destroying system that we have today? I'm going to argue that this can be explained in one chart. You can tell me if you agree. So here's the last 50 years of U.S. healthcare explained in one chart. And I think it'll help make all those other charts I showed you make more sense. So in 1965, and also after World War II with the employer-based system, but let's talk about 1965 specifically, we decided it was unacceptable that the elderly and the poor could not afford health coverage. So we enacted some very important programs, Medicare and Medicaid, to help solve that problem. But I don't have to tell GUIAN McKEE, who is one of the great scholars in this area, that one of the ways in which, the most important way in which LBJ fought off the American Medical Association, which at the time was the biggest opponent of national health care, was he said, if you just shut up about my Medicare bill, I'll let you charge your usual customary and reasonable rates. So the AMA said, okay, fine. And guess what happened? Consumers of health care became like me at an open bar, which is to say they didn't care about the price. They said, get me that Whistle Pig rye bourbon, and someone else is paying the tab. And that's basically how we are about our health care today. We say, you know what, okay, it's paid for, at least in large part, particularly on Medicaid. Get me the best, doc, I want to go to the best hospital. I want the procedure that's going to do the best to save my life. I've paid my taxes. Give me the service. And guess what happened? The hospitals and the doctors and the drug companies all woke up and said, hey, this is great. We can charge more for our services and nobody cares because the bill is being paid for by somebody else. That's why a lot of the hospitals in America are really ugly, because a lot of them were built in the late 60s after Medicare and Medicaid were passed, and that was like a nadir of American architectural practice, in my view. So then, of course, the bean counters wake up and say, wow, we're spending more on health care than we thought. Here's a great statistic for you. In 1965, when the Medicare bill was being debated in Congress, the House Ways and Means Committee projected that in 1990, we would be spending $10 billion a year on Medicare. Does anyone know how much we were spending on Medicare in 1990? $110 billion. Today we're spending $800 billion on Medicare. We're going to be at $1 trillion pretty soon. Well, why did that happen? It's because of, it's basically me at the open bar again. The fact is, you have the government spending more because they thought that the growth of Medicare spending would match inflation. Actually, wage growth was what they tied it to. But they didn't account for the fact that once you make something free, or at least a lot less expensive for people, people will consume more of it, and they will also be less sensitive to increases in its price. So of course, Congress was not going to kick people off of Medicare, so they decided to hire the bad cop of managed care to help solve this problem. This originally started in the Nixon administration, but is now a bigger part of the problem. And the government also tried to slow down the growth in payments to hospitals and doctors and skilled nursing facilities and others to try to slow down, to wrestle this planet-destroying beast that had grown out of the Medicare program. Well, the hospitals can't tell the government what to charge them, but the hospitals can tell private insurers what to charge them if they consolidate and become regional monopolies. So that's what the hospitals decided to do. They said, okay, let's create regional monopolies, so if we can at least make more money off of Medicare, we can charge people with private insurance more. And so, of course, once providers, both not just hospitals, but drug companies and doctors charge private insurers more, and private insurers are not in the habit of going out of business, so they pass those higher costs down to consumers in the form of higher premiums. And no big surprise, if the premiums keep going up, tens of millions of people won't be able to afford health insurance. And so, because we're concerned about this problem, we figure we should solve it by subsidizing health insurance for more people. So this is not to say that we shouldn't strive to make sure that every American has health insurance. But the peculiar and particular way that we did it in the United States is the reason why health care is so expensive here. We have the worst of both worlds. We have a system in which almost everybody in America gets subsidized health insurance, but there's no mechanism for reducing the cost or utilization of expensive products, and also to regulate price. So you have to really go, if you want to have an economically coherent system, you have to go one of two ways. You can have a single payer system in which the government is the insurance company and the government is dictating price and rationing care. That's one way to do it. That works, as we saw with Canada and the UK, at least in terms of the fiscal piece. Or you can do it in a market-based way, in which healthcare works a little bit more like the rest of the economy, where you have a private insurance system. Yes, you provide financial assistance to the people who need it, but at the end of the day, consumers have an incentive to shop for plans like you do in Medicare with the Medicare prescription drug benefit, where the premium is low. If insurers are competing to keep your premiums low, then the insurers have an incentive to drive a tough bargain with the hospitals and the drug companies. And that's a different way to have a check on the system and control costs. We do neither of those things because of the way that we've designed the system over the last 50 to 70 years. So I mentioned Switzerland as one country that we'll go back to as a model for how to reform the system, and we'll get into that more in a minute. The president, of course, says, well, you know, we tried to solve all these problems. Well, here's some of the problems that the Affordable Care Act has not solved. We all know about how it has expanded coverage, but here are some of the problems it hasn't solved. One is the rise of these regional hospital monopolies. So I'm not going to explain all the math in this chart except to say that the blue bars are the number of hospital mergers that have taken place every year. The red line is the line above which, as the hospital markets get more and more concentrated, the Federal Trade Commission and the Department of Justice are supposed to intervene based on their standard policies and try to break up these mergers. And we're at a point now, as the green curve shows you, that pretty much every hospital merger in America is now one that should be litigated on antitrust grounds, because we're now over the threshold almost everywhere in terms of the concentration of hospital markets into monopolies and oligopolies. But the FTC isn't doing that, because hospitals have this prestige factor. Who really thinks that the UVA medical system is full of evil people who are trying to profiteer off the poor, right? People assume that hospital systems are public-spirited. And when the hospitals merge, the hospital CEOs all get together and say, look, we're going to integrate care, and it's going to be so great, and there's going to be all this coordination and all this value. Well, academics who have studied this have found that actually, if you look at how patients fare after mergers happen, there's no effect on health outcomes, none. In fact, a lot of studies show that health outcomes decrease. Some show a modest increase, but most show basically no effect. That's on health outcomes. Where there clearly is effect when hospital mergers happen is on the prices that hospitals charge. So an economist at the University of California did a beautiful study where he split up all the hospital markets in America into two buckets. One bucket was the ones that are, on average, more competitive, which are the blue bars here, and the red bars, which I'm going to come to next, are the ones that were less competitive, more consolidated, more monopolistic. And he looked at the prices of 6 procedures: angioplasty, pacemakers, knee replacement, hip replacement, spinal fusions, and, well, 2 different kinds of spinal fusions, and found that if you actually look at the more concentrated markets, the average increase in price was 44%. Not because the underlying cost of caring for those patients was any higher, but just because the hospital had the market power to charge more. Because when you have a couple different hospitals competing against each other, the insurers can play those hospitals off of each other. Say, hey, if you're going to charge too much for knee replacement over here, I'm going to send my patients to this other hospital that's charging me less. That's how competition works. But when there's a monopoly on the hospital side, that competition breaks down, and the insurers are forced to accept whatever rate increases hospitals want to charge. Another problem is the rising cost of prescription drugs. Famously, the Affordable Care Act, the authors of the Affordable Care Act were very concerned that Hillary Care had been defeated by the hospital lobby and the drug lobby. So they went about making sure that the hospital lobby and the drug lobby were very happy with Obamacare. And one of the results is that there's been an explosion of spending in certain categories of drugs. One of them is so-called orphan drugs, which are drugs for theoretically rare diseases that affect, according to law, fewer than 200,000 people in the U.S. And what you're starting to see is that because drug companies can charge $1 million per patient per year for these rare drugs because a kid with a genetic disorder is seen as a very sympathetic patient. Who cares what it costs? Just develop a drug to help that patient. Well, that's the majority of the drugs that are being developed now in the biotech pipeline are these drugs for rare diseases because you can charge more for them, and that's why spending on those drugs is exploding. So-called rare diseases are soon going to be more than a third of what overall drug spending is. And by the way, the coverage numbers under the Affordable Care Act are not that great. When the Congressional Budget Office scored the original Affordable Care Act bill in 2010, they assumed that by now we'd have 25 million people enrolled in the Affordable Care Act's insurance exchanges. But every year since, the CBO has had to downgrade its estimates. So we're now actually 16 million short of where the Affordable Care Act's enrollment in the exchanges was supposed to be. And some people have said, well, that's Trump sabotaging the system. No, this is a problem that has always been there because the premiums have been so high under the Affordable Care Act that a lot of people can't afford the insurance unless they're getting fully subsidized, and that's what the next chart will show you. So basically what the Affordable Care Act has done is it's been very successful at expanding coverage to people whose incomes are near the federal poverty level or below. If you're below the federal poverty level, you're on the Medicaid expansion. If you're above the poverty level, you're in general on the Affordable Care Act's insurance exchanges like the healthcare.gov website. If your income is close to the federal poverty level, you're signing up. Because the way the subsidies work, you get a bigger subsidy if you're closer to the federal poverty level. As your income goes up the scale, you get less financial assistance. This was actually a concept that Obamacare borrowed from Switzerland. But the problem is, because people at the upper end of that scale are getting less financial assistance, that financial assistance doesn't compensate for the rise in the premiums. So if your premium goes up by $200 a month, and you're getting a $50 a month check from the government, it doesn't help you. You're still down $150 from where you were in the old system. So a lot of those people are not signing up for coverage, and that's why the Affordable Care Act has gotten sticky. A lot of people think this is because the Affordable Care Act protects people against pre-existing conditions. That's not true. I won't bore you with all the numbers and the math on this chart, but the point of this chart is to say that actually there are a couple of regulations that people don't talk about a lot that are driving why the Affordable Care Act premiums are so high. And the biggest and most important is the fact that the ACA overcharges young people to sign up for coverage. So in a conventional insurance market where the insurance is priced to the actual healthcare consumption that the average person has, older people consume about 6 times, a 64-year-old consumes about 6 times as much healthcare as an 18-year-old. But in the Affordable Care Act, you can't charge 1/6 of the premium to the 18-year-old. You can only charge 1/3 of the premium to the 18-year-old. Which means a lot of those 18-year-olds or 27-year-olds are dropping out because they're like, why should I pay $200, $300 a month for health insurance I'm never going to use because I'm perfectly healthy and I never go to the doctor? So they're dropping out, even though there's theoretically a mandate, or at least until this year, trying to force them in. They ignored it because the penalties were not that big. Here's the other big problem with the ACA is that it expands coverage to low-income people through Medicaid. About 2/3 of the expansion that's happened has been through Medicaid. The problem is a lot of doctors don't take Medicaid, because Medicaid pays doctors a lot less than Medicare and private insurers pay. So what this chart is showing you, it's a survey of if you actually call up a physician and say you have private insurance, a physician you don't have a relationship with already, and you ask them, can I get an appointment? Will they say yes or will they say no? If they say no, it's part of this blue bar. So a lower number is good here. A lower number means that you're not getting rejected by that doctor for having private insurance. The fact is, if you have private insurance, you have Aetna, you have Blue Cross, most doctors will take your coverage and say, fine, when can you come in? But if you're on Medicare increasingly, as Medicare phases down what it pays doctors, a lot of doctors are starting to say, you know what, I don't have room for you. Sorry, I'm too busy. And in Medicaid, it's even worse. So you can have this card that says you have health insurance, but if you can't actually get an appointment to see a doctor, or if you have to spend a lot of your time to finally get that appointment to see a doctor, the insurance is not as meaningful to you. And these disparities, this is data from 2008, these disparities have only widened in the last 10 years. So okay, so if there are still excellent problems in our healthcare system, what should we do about it? You all know about the Democratic push for Medicare for all. I won't spend a lot of time on this. We can talk about in the Q&A if you want. But the basic problem is that it's going to spend an enormous amount of money, because to take all the spending that's now at the state and local level and the private level and make that the federal government's responsibility will require such a massive increase in federal taxes and federal spending that you basically can't do it. It's just too disruptive. So the smarter Democrats, including Nancy Pelosi, are actually trying to figure out more subtle ways to expand the role of public insurance over private insurance in the system. I'm sure over time that you will be hearing more about that. You may see ballot initiatives around Medicaid expansion and Veterans Administration style drug pricing in states where that can be interesting. And by the way, what's interesting about this coming presidential race, unlike previous ones on the Democratic side, is that the superdelegates, which have had such an impact in the last 50 years on the Democratic side, they will not have a vote in the first ballot. The DNC changed its rules. And every candidate running for president knows that. So they're moving more to the left, particularly rhetorically, because they know the superdelegates are not a check on the base of the Democratic Party. And so I would expect that there's going to be a lot more. That's another reason why. The left is already more energized in the Democratic Party, but they're going to have more power, actually, in selecting the nominee of the Democratic Party because of this change. And so that's something to keep an eye on. So, okay, I've done a lot of complaining. So let's talk about some of the opportunities for solutions. I'm going to go back to this chart. This is the chart I told you was the most important chart that I was going to show you today, the one about government spending per capita on health care. And I mentioned that single-payer countries like the UK and Canada spend less than the United States in terms of government spending, and they cover everybody. But they're not the only countries that spend less than the US and cover everybody. So too do Switzerland and Singapore, countries that, again, as I mentioned before, have market-based systems, more market-based than the US, and yet are way more fiscally sustainable than either Canada or the UK or the United States. Well, how is that possible? What is it that they do? So let's talk about Switzerland first. Switzerland has a system which is basically like the Affordable Care Act exchanges for all. So it's Obamacare for all instead of Medicare for all, I guess you could say. And basically the way it works is there's no Medicare. If your income is low, just like on the ACA exchanges, you get assistance to pay off your premiums and your copays, just like you would if you were 52. So the same system that applies to a 64-year-old in the US applies to a 66-year-old in Switzerland. And there's no Medicaid. Basically, if you're low income, you need health insurance. You get insurance through the same system that effectively the Affordable Care Act does. So basically, what they do is very similar to what we do, not just in the ACA exchanges, but with the Medicare prescription drug benefit, Medicare Part D, and also what Paul Ryan proposed as a reform of the overall Medicare system, which is to say there's a premium. That premium is benchmarked to what a bunch of different insurers offer their premiums, and the second cheapest one, or in the case of the ACA, becomes the benchmark that the federal government will subsidize. If you want to pay more than that, you can, but you don't have to. And that's a system that works really well in Switzerland, unlike places like Canada and the UK, where there are well-documented problems with access to technology, access to knee replacements, access to the latest drugs. Switzerland has none of those problems. Switzerland has access to all the latest technologies. You have complete freedom of choice of doctors, so things that Americans really care about, but again, in a system that spends a lot less money and covers everyone. Why do they spend so much less money? Because they only subsidize the people who need the help. In America, all of us in this room are paying taxes so that Warren Buffett and Mitt Romney can have government-subsidized health insurance. Why are we doing that? Why are they even eligible for Medicare? We shouldn't be spending money so that they can have subsidized insurance. We should be spending money so people who are struggling to afford health care can get health insurance. And that's the Swiss model. Singapore has a different system. They spend a quarter of what we spend on health care in terms of government spending. They have a single-payer system for catastrophic insurance. So you get hit by a bus, you have a stroke, they cover that. But everything else is paid for through health savings accounts that individual patients control. And for low-income people who otherwise couldn't afford to save, they subsidize that health savings account. So they'll deposit money in your bank account for you. And they use their equivalent of the Social Security tax to route into those health savings accounts. That system works really well in Singapore. So how can we adapt some of those principles to have a more market-based system of universal coverage in the United States? And I'm going to show you how you can do it in 4 steps. The first step is you've got to make the purchase of individual insurance work. So the biggest problem in our system, as I mentioned, is the open bar, right? Where somebody else is paying for your insurance, whether it's Medicaid or Medicare or even in the employer-based system, where most of us who have employer-based coverage, we have no idea what the employer is spending on our health premiums. Ask any professor at the University of Virginia if they know how much the University of Virginia is paying for their health insurance. I'm sure almost nobody, maybe 3 people on the entire faculty know the answer to this question, right? The same is true for any employer. because it's taken out of your paycheck pre-tax, and you're not paying for it because of the tax subsidy for employer-based coverage. So if we want people to move to a system where they're buying their own insurance, like we do for car insurance and homeowners insurance and everything else, that insurance market has to work. The ACA did some good things to help make that market better, particularly the financial assistance for lower income people, but the regulations in the ACA overshot the problem, and that's why the premiums are so high. So you've got to reform some of those regulations so the premiums can go down, and you can have more choice of insurers that can compete against each other, and you also can do more to subsidize coverage directly for sick people so that young and healthy people don't have to pay higher premiums. They can actually pay lower premiums than they do today. So that's the foundation, because if that market doesn't work, you can't move to a more market-based system overall like the Swiss model or the Singaporean model. The next thing you have to do is you actually have to tackle the underlying cost of healthcare. And the two biggest components, both in terms of their size and their growth, are hospital spending and drug spending. Together, that's about half of all of what we spend on healthcare, as I showed earlier. And they're also the parts, as I said, they're fastest growing. Why? Because that's where monopoly power is strongest. Hospital monopolies keep raising their prices, and innovative medicines, because of patents and other features, are legal monopolies to a degree, but they're also artificial monopolies that are created by Congress and FDA almost accidentally, or there are loopholes that companies take advantage of to extend their monopolies, or they're not warranted. The next thing you have to do is apply some of these principles to Medicare and Medicaid. Again, why should people on Medicaid not have the option of buying coverage on the exchanges, buy their own individual insurance? That really matters for low-income people, because in one month your income might be 90% of the federal poverty level, another month it might be 120% of the federal poverty level, and you have to disenroll from Medicaid and re-enroll in the exchanges, and you may have a different primary care doctor and a different provider. It's hard enough for people who are poor to manage their everyday lives without having to re-enroll and disenroll from health insurance every month. Right? So why should you have to cross that barrier all the time and be in multiple systems? Put them in one system and let the level of financial assistance maybe change up and down, but let them keep their insurance. Don't penalize them because their incomes go up and down. And in Medicare, why is it, again, that we pay taxes so that Warren Buffett can have Medicare? And we can also do things to make Medicare Advantage, Medicare Part C, look more like the exchanges and Part D, where today we pay plans basically a fixed dollar amount for every person that's covered in Medicare Advantage. Why not let the plans compete more aggressively for those patients? Because that'll drive down the costs and the premiums. That means more savings in seniors' pockets, because then they don't have to pay a premium for their Part B component of Medicare. But it also means the government spends less money. The taxpayers and seniors can win. So you can lower the cost of covering people by encouraging more competition among insurers. And there are a lot of other things we can do. Why don't we let veterans who are having trouble accessing care in the veteran system get involved in this kind of a system? Let's deal with medical malpractice. Let's make sure that we're reforming antiquated laws that prevent technologists from figuring out how to use and transmit our health data effectively among providers. If you've got 5 different doctors you're working with and a hospital over here, and they're not allowed to coordinate with each other, well, that's one reason why hospitals claim they're merging. They're claiming that they're merging and buying all these doctor practices because then they have access to your patient data and don't have to go through all the bureaucratic hoops to share it with somebody else. Well, why don't we modernize those laws so that you don't need hospitals to merge and consolidate to have that effect? If you do all that, the previous version of our reform plan, we found that we could actually save $10 trillion over 3 decades. We would make Medicare permanently solvent so that everyone on Medicare today would know Medicare will never go bankrupt in your lifetime. And we can also make state budgets more flexible, because as many people know, for every state budget, Medicaid is the second or largest line item in the budget and growing to a point where they can't control their spending. And you cover more people because you make health insurance less expensive. You get to true near universal coverage, and you improve health outcomes for the poor by making sure that the poor have access to physicians when they have health insurance, and also you get rid of this churn where they have to change their insurance plan every time their income goes up or down. So how can you actually tackle the high cost of health care? Again, we have an LBJ scholar here, so I was inspired to put this LBJ picture in my slides. You know, I mentioned that LBJ took on the American Medical Association, which was the special interest that he had to deal with. In today's world, the doctors are a part of the problem, but they aren't the biggest part of the problem. The biggest part of the problem is hospital monopolies and drug companies. Those are the special interests that have the power in our healthcare system. And I want to highlight one example of You might think, how can anyone actually do this? The special interests are too powerful. Well, there's a congressman from Northeast Indiana named Jim Banks who introduced a bill just a couple weeks ago called the Hospital Competition Act of 2019, which is based on the work in our reform manifesto or white paper on tackling hospital monopolies. It's co-sponsored by another congressman from Arkansas. It quadruples the Federal Trade Commission's budget specifically to tackle hospital consolidation. One big problem is a lot of these hospital mergers are local. The FTC is a national agency. They're focused on national mergers, like when Comcast and Time Warner want to merge, or American Airlines and U.S. Airways want to merge. Those are the things they care about because those are national mergers. A local merger, they don't have the time to deal with it. But in aggregate, all these local mergers are a national problem. So it quadruples the FTC budget to do antitrust enforcement, but it also incentivizes large hospital systems to divest their subsidiaries into independent freestanding hospitals so that they can compete against one another. How does it do that? It forbids hospital monopolies from charging prices that are higher than Medicare's. Right now, the average hospital charges a privately insured patient 70 to 90% more than what they charge someone in Medicare. Why? Because they can. And so what we do here is say, look, if you want to be in a competitive market where there are 5 different hospitals competing against each other, go to town. Have market-based pricing, compete on price and quality. But if you're going to be a single dominant player in a given region and you're just charging whatever you want because you can, we're going to regulate that. So that's the way to incentivize competition. The real case for single payer, in theory, is that, again, you can regulate prices. This way, you're only regulating prices of the monopolies, but you're letting the market work where competition is a dominant factor. So it's a more surgical way of tackling where the problem is and not having a true overall price regulation system. If you want to read more about it, this is the publication we put out in 2016 called Transcending Obamacare. You can download it from our website, freeop.org. We're putting out a new document called Affordable Healthcare for Every Generation, which focuses on these kinds of bipartisan reforms that we hope that both Democrats and Republicans can embrace to make healthcare affordable, not just for the people who need it today, but for our kids and grandkids who need an affordable healthcare system when they're our age. With that, I thank you and I yield to questions. Did I go on too long?
No, that was great. Okay. That was great and very clear on some let's say complicated issues. I'm going to keep my interview portion pretty short, so we have time to take questions from the audience. But I do want to start off with one sort of big picture question and one where I'm going to ask you to look into the future. The big picture one is I think about this model that you set out. I see kind of 2 core problems. One on each side, Republican and Democrat. For Republicans, I know with the attempt at the ACA repeal, you kind of went toe-to-toe with Paul Ryan on the idea of whether the tax credits should be means-tested. And long-standing resistance to the idea of means-tested subsidies, I think, and correct me if I'm wrong, in the idea that promotes dependency on government.
Yeah, and redistribution,
and
too.
Redistribution,
and it's
absolutely.
a disincentive for work. Like his theory was, you make more money, you get less of a benefit, so that discourages you from making more money, which I get in theory, but it actually in reality, nobody thinks that way. If I make $1,000 more in income and I get $50 less in federal assistance, I still want the income.
Yeah.
So.
Yeah. This kind of goes, I guess, to the free op project on the Republican side or the conservative side more generally. How do you move people past that ideological principle to get to a political solution that might move in these directions that you're suggesting? Yeah,
and it's a big part of why, when people will say, what are you? Are you guys a conservative institution? Are you a centrist? What are you? And I say, we're none of those things. We're actually a hybrid where we're trying to advance conservative and progressive values at the same time. Why is that so important? Because in our mind, it is a false dichotomy. There are ways to achieve progress for those who most need it using ideas and policies that Republicans or conservatives can embrace. And means-tested subsidies is a key part of that. If you actually have a system, as Switzerland shows, where we really focus our financial assistance on people who need it, yes, it's more redistributive than the system we have now, and that's an itch that Republicans don't like to scratch. But you actually, from a taxpayer standpoint, that would be a much more fiscally sustainable system than we have when we have now. So would you rather go broke, or would you rather have a system that's more redistributive? That's kind of the way I'm trying to frame it to those guys.
And you might challenge some public perceptions about Republican priorities.
Sure,
on the
absolutely.
way. Well, the analog I would point to on the Democratic side of sort of where the ideological foundations come in, assuming you can get past the idea that insurance companies are the source of all problems in the healthcare system, would be the argument about the potential bargaining power of Medicare for All. That with that large a player on the payer side, you could actually challenge the pricing power of hospitals, and physicians, and pharma. Just the size of that government insurer alone. That's going to be the answer. The challenge I think you'd get from a lot of Democrats at this point. What's your response to that critique?
Yeah, I think that it's a reasonable point of view. I think there are two problems with it. The first is, actually they're kind of related problems. The first is that what a lot of single-payer advocates in this country don't appreciate when they say, well, look at Canada, look at the UK. We have a constitution that guarantees the right of lobbyists to petition our government. And that's not something that's true in a lot of those other countries. Right? So you have a single-payer system where Medicare, say, or the government is running the healthcare system and setting the prices. Well, who's going to have the most influence on what those prices are? You or the hospital lobby? What do we see? What has history shown us thus far? Right? It's that when the government has that control, the lobbyists have a lot more influence than they already do. So you're kind of, in my view, you're actually going to hand over more power to the lobbyists. You're going to have more capture of the system by special interest if the government's running it. If it's a market-based system where the patients are effectively deciding what the prices are going to be by voting with their feet, that's not something that the private sector can manipulate as easily. So I think that's one element of the answer. And the second element of the answer is that, as I mentioned up here, by tackling the real problem, which is monopoly power, there isn't monopoly power everywhere. So there's regional hospital monopolies in some places, but not everywhere. There are drug monopolies in some places, particularly with rarer diseases, but not everywhere. So let's say you have high cholesterol. Today, the 12 most effective high cholesterol lowering drugs are all generic. So there's robust competition if you have high cholesterol, if you have high blood pressure, if you have depression. For a lot of common diseases, the competitive side of our market's working well, and the countries that have price controls actually have higher prices for those products. So my argument is that both from an economic policy standpoint, in terms of targeting the real problems in the system, and also from a political economy standpoint, would that single-payer system actually work, I have skepticism.
A question that I've always wrestled with in thinking about the nature of healthcare markets, and that's the effectiveness of price signals. You have an embedded issue of information asymmetries between providers and consumers, made worse, as you say, by the presence of significant financial middlemen. Can you actually make consumers, the patients themselves, aware of and responsive to prices in healthcare?
Yeah, so this is an idea that's been around almost as long, actually just a little longer than Medicare.
Yeah,
Ken Arrow, who was a professor at Stanford, or is a professor at Stanford. I think he was still at that time a professor at Stanford. The Ford Foundation actually asked him, you're this famous economist, do some work on healthcare. And he wrote this famous paper now where he made this argument that healthcare, you can't use market principles in healthcare because consumers don't have all the information they need. That was his core argument. He had others. That's true of almost every market. I mean, how many of you know what LTE stands for? Raise your hand. And yet all of you have a phone that has LTE on. Okay, there's one guy in the back, some whiz kid who knows what LTE is. There are a lot of things we don't understand about the products and services we buy, but we still manage to buy them and use them and feel fairly comfortable that the private sector can compete and innovate to deliver those services in a way that we want. The same is true of healthcare when we allow it. So people will say things like, for example, well, if you're unconscious, if you have a stroke, how can you shop for healthcare? Well, that's true. But not all healthcare is on being unconscious and having stroke. Let's say you need your knee replaced. You actually can look at the 10 different hospitals in your area and see which surgeon has the best reputation and which place has the best price. And even with that patient who has a stroke, you can shop for 10 different insurance plans and find the one that negotiates the best deal with the best hospital to give you the lowest price and therefore the lowest premium. So markets can work in healthcare. There obviously is a role for government in preventing fraud and regulating things to make sure that people can understand what they're buying. And there is a role for government assistance for people who otherwise can't afford insurance. But we've gone way beyond that in America. I've highlighted, I hope for all of you, so many of the distortions that have led our system to be a lot nothing like what a market is. So some people will say, well, there's an emotional component to healthcare that isn't present in any other part of the market. Well, like, you're wearing a blue tie. Why aren't you wearing an orange tie? Was that a rational economic decision, or was it you just happen to like a blue tie today, right? There are a lot of things that we do in this world. Any woman who has a designer handbag, or any man who has, a jacket from a famous company or whatever, we're all making emotional decisions. No one says let's have a single-payer fashion industry because there's no utility to the way we buy clothes. So to me, that argument was always not really well thought out, the Ken-era argument, and I think it's become a kind of religion for people who just are skeptical of markets in general rather than an actual way to think about where the government's role is most applicable and most useful.
Actually, I almost did wear an orange tie this morning.
Okay. Well, you got beat out by
but that's a great answer. I like that assessment of Arrow. One last question, and I'm going to ask you to look into the future. At some point, there's a push towards some form of Medicare for all. We'll say Nancy Pelosi has won, at least in part, and the proposal is actually to drop the Medicare eligibility age to, say, 55. Democrats control Congress, but they've got 52 votes in the Senate. They need 8 Republicans. What should the Republicans hold out for in that scenario?
Well, the Republicans will oppose it, just flat out. There is a theoretical possibility. I mean, there will be a push, at least among some Democrats, to try to do it through the reconciliation process and do it purely through 52 votes. They could try that. I think the key thing is going to be there's going to be a lot of debate on the Democratic side about the fiscal piece of it. So Medicare for all, again, it's a great slogan, it's a great bumper sticker. It's even less than 140 characters, but it could mean a lot of different things. So okay, if you're going to have a buy-in for Medicare, how much of the Medicare premium is going to be paid for by that patient versus by the government? If the patient's paying for all of it, that's going to be very unattractive insurance relative to the Affordable Care Act, relative to employer-based coverage. It's not actually going to be useful. No one's going to buy that coverage. If you heavily subsidize it, there's going to be a massive cost that the taxpayers will have to fund, and people aren't going to want their taxes to go up. So those are the kinds of devil in the detail choices that we have to get to long before you have to worry about what Republicans think.
Mm-hmm. What would be those Republican priorities, though, if they were at a point where they wanted to bargain?
Yeah, I think that the Republican approach will be to modernize Medicare in some of the ways that I've talked about. Not so much to drop the eligibility down, but to say for the people who are on Medicare today, how do we make the program more effective? Particularly when we see, and there's a remarkable academic consensus about this now, that the Medicare Advantage program, the part of Medicare that's administered by private insurers, is actually more effective, both in terms of health outcomes and the cost, relative to traditional Part A, Part B, original Medicare fee-for-service. So as that continues, it's important to see if we can figure out if that can be part of the solution. Private insurance for all, whether it's Medicare Advantage in the senior population or private insurance in the employer and ACA standpoint, can we expand coverage that way? I think that's where Nancy Pelosi is, actually. It's not so much about dramatic expansion, it's about strengthening the system we already have. And I think that's where there's an opportunity for bipartisanship, is to lower the cost and expand access. If we can get more people into Medicare Advantage plans where they'll do better, I think that's an area where you could get a lot of consensus. And on the drug pricing piece, by the way, the Trump administration, as you know, has been really forceful on drug pricing in a way that I think a lot of people didn't know if he was serious about it. And obviously Democrats care about drug pricing. So that's an example of a place where in this Congress, before the next president comes in power, there could be real progress. Yeah. And we're certainly playing our role in trying to advocate for that. Yeah.
I'm also just struck by your points about antitrust regulation. That's an old liberal theme going back, take it back to Woodrow Wilson. Certainly
Teddy Roosevelt.
Absolutely. Another place where you could see. And then, of course, the idea of competition appealing to libertarians and conservatives. It's another place there should be some consensus.
Yeah, there's division. I mean, there are libertarians who say, government intervention to prevent monopolies is distasteful. Yeah. And there are those who are more like pro-competition, like I am. And so, I think that's going to be an area where there is an opportunity. And we were talking before, how can you advance conservative and progressive values at the same time? A great example is monopoly power. Mm-hmm. People on the left have lots of reasons, understandably, to be suspicious of corporate power in general, but particularly monopoly power. So do people on the right, because monopolies for example, not just preclude competition, but they tend to lobby to protect themselves against competition. So for people who are against crony capitalism, monopolies are a big driver of that, and hospitals are the most important example of all.
Right. Let's take some questions from the audience, and please wait for Bunny to bring around the microphone so our internet audience can hear what you have to say. Start in the back corner.
For the 6 or 7 years that Republicans wanted to repeal Obamacare, what were the core components of what they were offering, and was it consistent with anything that you're suggesting?
Great question. We could spend an hour on that topic. Maybe I should write a book about it someday. As Guian alluded to earlier, there was a huge intra-Republican debate about so there was the repeal piece and the replace piece. There was a lot more consensus around the repeal piece than the replace piece. There were some people who were literally just repeal and go home. They said repeal and replace, another 3-word bumper sticker phrase, but for whom the replace was not really, they weren't really committed to that piece. That was, I think, a lot of Republican voters and frankly a lot of Republican politicians. Then you had the people like myself for whom repeal and replace was something that should be about reform, that should be about achieving a better and more universal system than the system we have. And then there were people in the middle who were basically trying to figure out how do we do something that politically comes across as viable, but also doesn't make mad the people who really just want to have repeal and go home. So there was no coherent agreement among Republicans as to how to, so one question I often get from conservatives is, AVIK, why wasn't there a plan that everyone agreed to and then just kind of implemented that? Why was there all this chaos and argument after Republicans got in power in 2017? And the reason is there were fundamental disagreements among Republicans about what the purpose of health reform was. For some, it was just go back to the status quo ante of the pre-Obamacare world, which, as many of us know, was not something that was not a model for anybody, not a serious model for anybody. But the people who were happy in that system said, I like the system, it works for me. Maybe it doesn't work for those people over there, but I don't care about them. That was basically the status quo ante. A lot of people wanted that. And then the people who wanted to reform the system there were people who were like libertarian fantasists who were like, just let's get rid of Obamacare, then we can get rid of other things later. That was obviously not realistic or productive. And then there were people like myself. So there was just no agreement, and I think they had to fail. Republicans had to fail at repeal and replace to be able to have the conversation we're having today where, my team, I guess you could say, and it's not just about Republicans, obviously, I run a bipartisan think tank, but that the people who are advocating within the Republican Party for the principles that I support, that they now are able to say, hey, like, you had your shot, now let's actually try to make the system better. And so I think you're starting to see now a more substantive focus. As I mentioned Jim Banks, and he's one of many examples. Paul Ryan's departure has actually helped with this, because Paul Ryan was kind of defining, particularly on the House side, what Republicans stood for. And with him gone and nobody to really take his place, there's a lot more creativity going on among the rank and file about how to solve some of these bigger problems.
So 20-some counties south of here, the people get sick more, they stay sick longer, and they die sooner than most Virginians, and certainly than most Albemarle County or Charlottesville people. Those are rural people. So how is the market-based solutions going to incorporate those people, in which way we're very different than Switzerland or Singapore? We have vast rural areas where there's no competition. If there's a struggling hospital, that would be a good thing if it's even 2 counties away. And there ain't no broadband, so you're not going to compare how to buy the best surgery.
Well, I don't think the lack of broadband in rural counties is something we should accept. I mean, we should make sure that there's broadband everywhere and that there's a market for broadband everywhere. So I see that as a temporary and hopefully not a permanent problem. In terms of the piece about hospital competition, yes, it's true that rural areas are inherently going to be less competitive than urban areas in terms of their hospitals, and we take that into account in some of the policies we propose, where the threshold for regulating a rural hospital monopoly is higher than for an urban hospital monopoly, because there you should expect more competition. But even in rural areas, there are things like telehealth and telemedicine that can play a big role in diversifying the access to health care that you have in a rural area. Well, you have to get that has to be fixed too. But the other question, the other part of your question was about health outcomes in rural areas, and rural areas that are impoverished in particular, where there's the opioid problem, where there's just broader public health issues. That's a broader problem. That's not a problem that, and I think we've asked too much of health insurance to expect health insurance alone to solve that problem. That's a much deeper problem that has to do in part with historical disparities in America, segregation and slavery preeminent among them, but also just things that we have to change about our culture, our eating habits, diet and exercise. So those are things that insurance can pay for the care that you need when you have diabetes, but insurance can't tell you to go to the gym every day. So I think I'm not saying that if we had a Swiss-style healthcare system, we'd all start climbing mountains and yodeling when we get to the top of them. But I am saying we'd have a more economically efficient insurance system.
Hi. This is a little off subject, but you mentioned the Veterans Administration. And my dad, a World War II vet and a physician, used to tell me that the VA medical system was only for indigent people. And when I got out of the military in the early 70s, I never considered using the VA for health care. And about 20 years ago, I talked to some people I know who were far from indigent, who had started going to the VA for drugs or for appointments or different things. And my sense is that, and I don't know this, but I never hear it talked about, that the problem in the VA is that all of a sudden, because of high health care costs, so many more people who are using it who wouldn't have used it before. And I'm just wondering why that isn't part of the debate, that if you solve the health care cost issue, the VA issue would go away.
Yeah, VA healthcare is a really important topic. I've spent a lot of time on it. It's been a real privilege to be involved in it. And I worked in, as all medical students, most medical students do, I worked in VA hospitals during my medical school training. The actual history of the problem is the opposite of what you described. So the VA hospitals actually were built at a time when we didn't have the hospital infrastructure we have today. When you had people coming back from the Civil War, particularly from World War I, that were injured, that had lost limbs because of landmines in Belgium, and they needed a place to get care, and we didn't have hospitals built out all over the country. So the VA system built those hospitals to serve those veterans coming home from World War I, which was a very short war from the American point of view, but a massive influx of wounded and disabled veterans as a result. So the original idea of VA healthcare was that it was a kind of workers' compensation. If you serve in the military and you get injured, the VA system is supposed to be there for you to take care of you. A very noble and appropriate role for the government. Over time, as so World War II, the World War II veterans are aging out, even the Vietnam veterans are aging out, so fewer and fewer people are using VA facilities because we're not going to war as often with as large of a population. And so the VA system, as a way of filling their beds, expanded utilization of the VA to indigent veterans as opposed to purely veterans who actually had battlefield injuries. So over time, there's been a mission creep at the VA, and that's led to, in part, to the problems the VA has today. I mean, what we propose in part, we propose giving veterans the access to the dollars that are being spent on their behalf to buy private insurance and private health care if they want. But a big part of it, too, is the VA hospital system can be part of the solution to hospital monopolies. Where there are VA hospitals and there's a private hospital next door, why not let the VA hospital compete for patients? Take patients who are not part of the veteran, who aren't veterans, and serve those populations. Now, that's politically sensitive because a lot of veterans will say, hey, this is my system, don't you touch it. But to me, it's a trade. You let VAs, the veterans who are using the VA have broader access to health care. In exchange, let civilians have broader access to the VA, and both systems can work better in that regard. That's part of our reform proposal.
Thank you for coming to speak with us today. I have two questions. The first, mostly regarding the pricing that you talked about with hospitals. How much do we know right now about where this spending, or if there is increased price, where is it going? And I'm asking that with the understanding that if physician salaries essentially have only grown essentially equal to inflation for the past recent history at least. What do we know about where it's going? And second of all, if we can change or decrease this price and therefore decreasing revenues and profits, how do you continue to incentivize both physicians who have extensive training compared to other countries, and then also Big Pharma, who usually is responsible, most people would argue, for the innovation that happens in the world when it comes to pharmaceuticals?
Yeah, boy, those are both big topics. Let's see if I can do it in a short period of time. So on the hospital side, most of the extra revenue goes to labor costs, salaries of executives, but also downstream, down level in the org chart. And people talk about, well, we could solve the healthcare problem if we actually take away the multi-million-dollar salaries of the insurance companies. There are only about 30 insurance companies. There are 4,000 hospitals. So there are a lot more multimillionaires in the hospital boardrooms than there are in insurance boardrooms, just because there are way more of them. So part of it is that the money's, it depends. So if nonprofit hospitals don't have shareholders, so the money is flowing to the people who work in those hospitals and who lead them. For publicly traded, private sector, for-profit hospitals, it can sometimes go to shareholders in the form of dividends or stock value increases. So that's where it's going, and it's also going to these shiny new buildings that you see everywhere. In a lot of towns, all the construction downtown is the hospital wing, the new wing of the hospital. It's not an actual business outside of the healthcare system. On the drug side, there is this this kind of zombie talking point you hear from the industry that we have to have high prices because innovation is so expensive in drug development. And there are two problems with that talking point, which I actually want to write a long paper about maybe in the next couple of days. The first is that you never hear the big pharma companies talk about how to reduce the cost of innovation. They only talk about justifying their high prices. The reason for that is because the high cost of innovation helps them. Because when the startup biotech entrepreneur develops a new drug, and they can't afford to bring it into costly clinical trials because they're a small company, what do? They sell the rights of that drug to Pfizer or Bristol Myers or Merck. That's how those big companies get their pipeline, because innovation is too expensive for startups and entrepreneurs and disruptors. So you'll never hear big pharma or big biotech lobby to reduce the cost of innovation. There's a lot we can do to reduce the cost of innovation. That's point number one. Point number two is, not all innovation is equally expensive. So basically in drug development, the highest costs of innovation come from the clinical trials. It costs about $10,000 per patient to do a clinical trial. If you're developing a new drug for diabetes, because tens of millions of Americans will be treated by that drug potentially, the FDA makes you do very large clinical trials. It could be 20,000 patients. Well, a 20,000 patient clinical trial is $2 billion. If you're developing a drug for a rare orphan disease that only 4,000 Americans have because it's a rare mutation, you might do a phase 3 clinical trial that involves 40 patients, not 2,000 or 20,000. And the R&D cost for that drug might be $50 million, not $2 billion. And yet, those are the drugs that have the highest unit prices. The drugs that have the lowest R&D costs are the ones where drug companies are charging the highest unit prices, $300,000, $500,000, $1 million per patient per year. They can't get away with those prices in diabetes. Why? Not because of price controls, but because there are 20 effective drugs for type 2 diabetes that are off patent. So it's not the government, it's not price controls that are preventing innovation. It's competition that's challenging companies to develop drugs at a lower cost. And yes, there are things we can do to make sure the FDA is reforming itself so that innovation for diabetes and heart disease is less expensive than it is. But again, you'll never hear Big Pharma talk about that. When I've come to them with proposals to reform the FDA to lower the cost of innovation, they shoot it down because it's not what they want.
Thank you for coming and doing this. As a foreign medical graduate, I'm interested in models of healthcare systems other than the United States. And I made the big mistake of looking at OECD data and then find that among the 30+ countries, we in the United States are an outlier in terms of cost, as you have described. But we are also, excuse me, an outlier in terms of outcomes. And using the crudest overall measure, life expectancy. So the next question then is, which healthcare systems are doing well in the cost per capita and in terms of life expectancy? And there is a cluster in which you could find a bunch of countries that are doing quite well. So why not throw a dart at them and pick one, anyone, and what we might end up with if we wholesale adopted it, which I realize would be naive as a proposition, but if we did so, we would save per capita per year more than $5,000 in excess cost above the average. And as a bonus, we would experience a life expectancy more than 2 years above and beyond the OECD average. I'm sorry, what we have now. And that would amount to, if I do rough calculations, a cost savings of somewhere around, more than $1 trillion a year.
So let me address, you've raised a number of different points before I lose track of them all. A couple points to make. One, we all have to die of something. So you're never going to save money in the healthcare system by living longer. It's good for public health if we all live to 120, but you know, you're gonna get something, right? Maybe it's Alzheimer's, maybe you're in a wheelchair, maybe there's some new disease that we all get when we're 120 that no one's ever heard of. But we all got to die of something. So since immortality is not possible, healthcare expenditures for the elderly will always be high. And the other piece of it is that life expectancy gets talked about a lot in terms of health system comparisons. It's a very poor way to compare healthcare systems, right? Because there's a lot that goes into life expectancy. So if you actually, for example, disaggregate gun fatalities and motor vehicle accidents, motor vehicle fatalities from life expectancy data, just those two things, the U.S. actually has the longest life expectancy in the OECD. And there are a lot of other things about healthcare and life, or life expectancy, that aren't about intervention in terms of medical intervention. So a better way to think about whether the healthcare system is actually working to extend life is to look at things like, okay, you're diagnosed with breast cancer. How long do you live? You have a stroke. How long do you live? You have a heart attack. How long do you live? Those are things that you can actually say, okay, the healthcare system is intervening there. Is it doing a good job or not? And on many of those measures, the United States actually does reasonably well. There's another piece, of course, that's very important, which is that, as I alluded to earlier, we have this unique problem of the legacy of slavery and segregation, which leads to major disparities in health outcomes for African Americans versus everyone else. If you actually just take out African Americans and look at the non-black U.S. population and look at all those statistics you just cited to me, we do just as well or better than most countries in Europe. So all this to say that yes, it's important to care about health outcomes and to make them better, but it's not, and that's where you can't just say, oh, look at the Swiss, they have such great health outcomes, let's import that. It doesn't really work that way. Well, cost, well, you've heard me talk about that quite a bit. If you had the Swiss system, just on, and the Swiss system in the European context is one of the relatively more expensive. It's also one of the richest countries in Europe, but it spends more on healthcare relative to GDP than other countries in Europe do, but their unit prices are way lower than the U.S. And I think that's part of the, so if you actually took the Swiss system and Swiss unit prices and Swiss federal spending on healthcare and you applied that to the U.S., we wouldn't have a budget deficit. That's how powerful the math is, if that's what you're getting at. So that's why these things really matter. And I'm not saying if we had half the performance of Switzerland, think of how much fiscal impact that would have, right? So that's why this is so important. That's why the conservative piece of this, that's why it's called, the title of this talk was called The Conservative Case for Universal Coverage.
We have two more? Okay.
Hi, my name's Lise. I'm a PhD student here in the School of Nursing. I'd love to hear a little bit of how quickly you would see things changing if we do change our prices. Are we already so far in debt? Are we already so far in over our heads that people expect to pay a lot of money for health care? Talk a little bit more about how quickly we could see things changing and what is that big one that's going to push the cliff to have things follow in that trend.
Yeah, so as I mentioned, the two big ones are hospitals and drugs, because those are again, they represent about half of healthcare spending, and they're also the areas where monopoly power leads to the most spending growth. So if you can tackle those two things, you can get somewhere. And by tackling, it doesn't mean like the prices have to necessarily collapse. If you can get flat to even slightly negative growth from an inflation-adjusted standpoint, and the economy grows at 3–4%. You can actually solve a lot of these problems over time. And if you think about it from a fiscal standpoint, the way investors think about it, because investors buy treasury bonds, investors buy bonds in Fortune 500 companies, what they're looking for is progress. They're looking to see, are you getting your house in order such that I don't mind paying interest on the debt you have today if I know that in a 20, 30, 40-year time horizon, you're going to be okay. So changing that so-called bending the cost curve really does matter from a standpoint of the bond markets, because if people see that your credit worthiness is going to gradually increase over time, that restores confidence and will lead to lower interest rates and solve a lot of problems in terms of our interest spending as well. I think that was your question, right? Okay.
Final question, yes.
In the 2012 presidential election, Mitt Romney's plan in Massachusetts, whilst he abandoned it himself, was seen as a very viable plan. How much of that plan embodied the principles that you have articulated to us today, and is that still a viable plan going forward?
Yeah, so you're talking about the plan, the Romney Care plan in Massachusetts. You're talking about the 2012 presidential, his plan for national reform.
The Romney plan in Massachusetts.
In Massachusetts, okay, the 2006 plan. So the healthcare reforms in Massachusetts were successful at expanding coverage, but did nothing on cost. In fact, cost went in the other direction. There was a big merger between the two Harvard-affiliated hospitals, Massachusetts General Hospital and Brigham and Women's, that led to massive spikes in hospital prices in Massachusetts. In fact, what's now called Partners Healthcare, the consolidated entity, owns basically most of the Massachusetts hospital market. So that problem has gotten worse. They've tried to tackle it. They haven't really. And the stuff on drug pricing, you can't really do it at the state level. It's more of a national market and a national problem. So they did pass Health Reform 2.0, as it was called, in the Deval-Patrick administration, where they tried to tackle some of the stuff around hospital prices. But thus far, it's not having much of an impact. So I'd say that the thing that Mitt Romney did in 2006 that was related to this stuff is the Swiss piece. Right, the idea of having insurance exchanges where you're buying coverage that's relatively standardized, where the insurers are competing on price, and where you're getting some assistance depending on your income to pay for that. That's the piece that's common to Romney Care, Obamacare, and what we're describing here. But there are key differences in terms of the exact regulatory structure. Massachusetts already had a lot of these regulations in place when Romney Care came into effect. Romney Care didn't introduce those regulations. So, so insurance in Massachusetts was already expensive, and Romney Care was kind of a patch to try to solve that problem. What the ACA did was impose those regulations on every other state where they didn't have them before, and that's what led to the premiums increases elsewhere. So that's why when Mitt Romney, when he was running for president, said, look, this worked in Massachusetts, but it's not a model for the country because every state's insurance market is different, he had a point. A lot of people just kind of dismissed that point, but he really did have a point there. But I'd say broadly, this is much more ambitious in the sense of the problem it's trying to solve than the discrete problem that Mitt Romney was trying to solve in Massachusetts in 2006.
All right, this has been a wonderful session. Please thank me in joining AVIK for his comments today. Thank you all for coming.